Okay, here we are.
Here we are. Any questions since the last one last week? Great. Um, so it's so quiet now. Just to kind of review what we're going to do today. Based on the previous assessments, we're going to focus on joint workspace, meaning, so this feedback is killing me. So a joint, two bones that move relative to one another. So Joseph and I were just talking about this outside actually. So relative to one another, like we can rotate the tibia on the condyles of the femur. And then if we go, and that would be open chain, if we were to plant Chris, and then again, Joseph and I were just doing this, and we were to move, in a, this would be closed chain, sorry, open chain. We would then be moving the condyles of the femur on the tibia. So instead of doing this, we're also able to do this. So that's what a joint is. So with that, this actual space in here is the joint workspace. So that's where we're gonna like funnel like all the degrees of freedom that a joint can do, specifically flexion, extension, and then medial and lateral rotation. And this is where we get into the capsule workspace. So that's the rotational component of the joint and the capsule itself. And again, just to recap, at the joint or the capsule level, it has a rotational pattern to it, and so do like the deeper muscular structures of the knee joint, like the popliteus. So if this is the back of the joint, popliteus does that, and it pulls you into medial rotation. Make sense? Kind of quick recap. You can't hear me? Oh, I was gonna say just move closer. Because if I'm louder for you, I'm louder for me. Does that make sense? The difference between like joint workspace, capsule workspace, and those are the two things we're gonna kind of work on. And then on top of that, we also know that Chris has connective tissue architecture issues, being the actual scar tissue, and then underneath that, the site of rupture, his patellar tendon. So we're going to put in directional information into that connective tissue to create new architecture at that level. And then we're going to begin to load it so that architecture learns to behave like he uses his knee. So then we'll get into kind of load bearing capacity stuff there. Yeah. Question.
When you're doing some of the FR stuff,
Mm-hmm.
you're like using your fingers and you're giving it directionality.
Mm-hmm.
Can I use, if I'm doing this on my own, can I use like a lacrosse ball and do the same thing?
No,
Okay.
in a short answer, because you're not giving it any directionality.
I'm
Like
just
we have,
putting pressure.
so we have receptors that will detect pressure, but you're not telling like those cells any direction which those cells need in order to become tissue.
Okay. Okay.
Does that make sense? Answer your question?
Yeah.
So without further ado, we're gonna reassess the joint and make sure, have you been doing your homework stuff? Are you lying? Okay.
I've been doing a little bit, but
So,
it's been feeling really good and I've been using it. So
okay. So this is why we reassess every time. So we'll see if we're like actually kind of pushing our starting point further, meaning are we getting from like week one where we had like literally no rotation here, and then last week we had some, and then we'll see what we have today and kind of establish our starting point. So let's go into our testing position. So again, just retesting the actual rotation in the joint, testing medial rotation. Any pain or anything in there?
nope.
Any lengthening
Yeah.
out here?
Yeah.
Great. So that's a good sign, like we have some motion, and he is feeling like connective tissue come online, meaning like he feels length. So that's a huge plus. Because before this didn't move, and we also didn't feel length. So we're again living in like this joint workspace in the capsule. Question.
Uh, I don't know if I ever mentioned this, but after this surgery, I've had numbness on this side.
Mm-hmm.
Probably should have been that. But it's less numb now,
Okay.
and I can feel the stretch. Whereas, like, I can be like, oh, that's. I can feel my fingers, but it's just like a numb feeling,
Mm-hmm. Mm-hmm.
like not a, like a great, like, oh.
Okay. So hopefully we're creating more like proprioceptive awareness there, we'll say. And we can actually change like the proliferation of like uh what am I trying to say? Like sensory nerves. Like some if you like have if you're constantly moving and you just have like pain all the time, you'll develop a proliferation of like pain receptors.
Yes.
So it's why I'll tell people like all the time. They're like, "Oh, it hurts when I do this." I'm like, "Stop fucking doing it."
It's fair.
So then you'll start moving in like pain-free things and start telling your nervous system good things rather than ow, ow, ow. And you can start to change that over. You know what I mean?
I have an idea.
Okay, so here is passive medial rotation of the tibia on the femur. Can you actively control that? So if I just put your foot here, can you control yourself into rotation?
Yeah.
Try it again. So you can see there's still not quite a good amount of active rotation. Like you can see his tibial tuberosity like not rotating towards you, but you see a lot of movement here. Yeah. So I think we did this last time as I gave the example of like using the hamstrings as like horse reins. So the hamstrings will help medial and lateral rotation when the knee is flexed. So if you gently drive your heel down into me and then try to rotate and use this and then come back to neutral and then go. Keep driving into me here. What are we feeling here?
Stuff.
Do you feel like hamstring working, back of the calf working, your brain working?
Brain. I definitely feel like
Okay. So I'm gonna make a note. Oh, that. Just that so we know, like passively, we have actually decent medial rotation.
the first time I've ever said my medial rotation was decent.
This is the first time it's actually like been. Um, and then active is still like not great. Just write that instead of like degrees.
Professional opinion.
So like this ratio, we want to close this gap. And then what we'll also what I also want to make mention is like, if you happen to test someone's medial rotation passively, and it's like these are flip-flopped and there's like no medial rotation, but then they actively get more medial rotation, they're totally faking it. Because you can't move, like if I can't passively move this thing, you're not going to be able to actively move it because you can't move like where things don't move. Does that jive? Yeah. So we want to close this gap. So eventually we're going to have to put in strategies for him to neurologically be able to hold and like get into that position. So we'll employ that later on. So this will be something we can work on. Let's test ER. ER, ERO. Okay, so same thing, passive. Blocking the ankle so we can not just move the ankle.
How much do you expect to see tibial rotation?
It depends on the person, but like when we first assessed him, he had zero.
Yeah.
So I, given that this is week 3 and like he's done some stuff, I would expect some. Um, how much is hard to say. I can't be like, oh, I want 10 degrees by the next time I see you. Like I can't. Like life happens. I don't know. I would love a number, but I can give someone like a goal. Be like, give me 10, and you come back with 8. I'll be okay with that. But like it also comes down to like what does he need for like what he does. So he literally just doesn't have a great joint. So whatever we get will have huge effects. So yeah. Mhm. Mhm. The exact opposite. So if I'm using the tibial tuberosity as like my reference point, for medial I'm going to see it roll towards you, and for external I'm going to see it roll towards the wall. And no offense, but you're not doing it. You're just moving your ankle. So that's why I have him blocked in dorsiflexion, because I lock that ankle in and it's all up here. Yeah, so I don't have to hold this. I'm just feeling his like the knee tissue with this hand. And then down here, I'm locked him in here so I don't move his ankle and get like a false positive. So he's locked in, and then it's just strictly at the knee. And then laterally, like he had some before, so this wasn't really like a quote unquote concern. But we like to see equal internal and external, and now we have that, if that helps you too, Amy. So like if you have none on medial, I prefer none on the outside. Just kidding. What does this feel like? This feels a little different than.
Feel a stretch.
I feel like a lot of tissue restriction in here.
Yeah, I feel a stretch like
Hmm.
just generally.
So then, if you, without digging your heel in yet, do you have external rotation? So here he has good control of ER. So again, like this would still take precedent over this one because it's a weak point, meaning he doesn't have control over IR. So let's get control of this half of joint workspace. Know what I mean?
Yep.
So Chris also presented closing angle pain and restriction the last couple weeks, meaning when we went into flexion, he would say, ow. So we know through MRI now that he has a Baker cyst potentially, or actually.
I'm pretty sure it's Baker cyst.
Okay, let's
It's
just.
just like fluid,
Okay.
but in the back.
Yeah. So when I do this, do you feel like a swelling sensation? Not necessarily in the
Just a little
front,
bit
but
of pressure. Yeah.
okay. So do you still have
Out
that?
there. Out there. Yeah. But it's not like in the knee.
Mm-hmm.
It's definitely like
In a
in the
spot.
back.
Mm-hmm. And then no lengthening up here where my hand is.
No.
So whether that is like obviously there is something there that is preventing us from going further. So again, we don't feel connective tissue like come online, meaning like there's no stretching sensation, so we're not at length. Makes sense? So we can try to do like a Pales test or an isometric test to see if we can get this stuff to kind of, not kind of, it'll engage and see if we can get this stuff to work at a length and see if it'll decrease some tone in the anterior part of the knee and then give us some more range of motion and see if we still get that same restriction. And we can use that as feedback to like either A, we're going to get less pinching and more range of motion, and that's a positive test, or it's going to be the same, and then we have a different issue. So we just take it most of the way. And right there, you can feel it just stop.
Yeah.
So go ahead and just lightly kick your ankle up into me. So in the past, Chris has had an issue of not being able to generate force from here, and he would kick me this way instead of from the knee stuff. So this is actually much better. Great. I'm going to back away here and just hold here. And then still from my perspective, I feel Chris bouncing a lot. Like it's not a smooth contraction. If you kind of keep a close eye like on my hand and his ankle, you can see it kind of like I don't know what the word I'm looking for is, but
natural dance of a symbiotic relationship.
that's exactly what it is. Give me a smidge more of effort. It's like now I feel him try to pull that way. Like this is tough. So again, this is feedback. Like he can't generate a great deal of force through this stuff. Relax. So then we can try our test here. Yeah, Baker's cyst. So there is fluid in the back of the knee, and like a cyst type thing. That when we like squish it like this, it'll give him pain or restriction, or he was getting the sensation of like it pushing outward like a balloon. And how are we here?
That's a little tight.
Tight or
Back of the knee.
okay?
But it feels like more range.
It feels like a little bit. So we'll try it again and see if we get the same test. And just go light effort here. Stop that or go ahead and pause. So again, I can feel him compensate, and I just want it from right here. So kick that ankle up and meet that. I'm going to back away at the knee and really focus down here. So again, even if when we get like that little bit of range of motion, that's a new length and position for his nervous system to like learn to use, which also might be why it's difficult for him to produce force here because it's a totally new space. So this is just long and low effort, just teaching that nervous system to produce a tiny bit of force and just learn about this new position and length and all the information we're going to get from this position. Length of the tissue, velocity, are we moving through space? No. Push me here, don't let me bounce you. That. Again, you see when I cue him differently, starts coming down here. And this is very difficult. It's not difficult for like Chris, it's difficult for his nervous system to make this happen. Relax. And no change.
Well, my sensation is to. Right.
What do you feel here? Yeah, I can feel that stop right there.
Yeah.
And is that cysty?
Yeah.
Okay. Okay, so we're done with that. Like I don't feel like squishing a cyst any further. So where we're gonna go is, I'll pause right there. I still want to work on the actual architecture of the patellar tendon because obviously it's had quite a bit of trauma. And so we want to like try to minimize and reintroduce like order into this tendon. Meaning, if I switch that to, so there's the knee, patella, and then tendon goes this way, yes? So if we have a rupture and then reattach that, we're going to get fibrotic tissue that just kind of lays down in a wonky fashion, just however it lays down. So we're going to use FR, so the actual pinpoint manual therapy treatment to guide this specific tissue, to give it a force and a direction for a duration of time to stimulate the mechanisms that are going to bring in like fibroblasts, and then through force, those fibroblasts will get more information as to what to become. Yeah. So our aim is going to be like this line to try to tell them to be this stuff. Yeah. As opposed to just laying down scar tissue kind of thing. So here we go. So again, we're going to be palpating the tendon, start from the tibial tuberosity, and then we can just kind of like work the bottom half per se. So we'll start here, sink in as we kind of, I'm just using my thumbs to kind of find that tension in there. And then as I lengthen that stuff, I can feel it get that rise in tension. So when I feel that rise in like, meaning as I lengthen this stuff, do I feel that the tension go up with the length? And that's like, did we talk about the length tension curve last time? That's a no. Okay. So what we're gonna kind of as we use, so we have this, as we lengthen and like, and then this is tension. We talked about, I think, mechanical versus neurological tension. So like as we lengthen, we should see a 1-to-1 kind of ratio here. So as length increases, tension will increase like gradually. Whereas if there's neurological tension, like if the nervous system is like preventing length from occurring, we're going to see like a quick like ramp up in tension. Makes sense? So we're feeling right now this line occur. So as we lengthen the patellar tendon, we're going to feel tension rise. And so that's where we'll start to put on our inputs when we feel like that length. We'll sink into that. And I'm just driving straight up. So while we do that, anybody have any questions or anything? There's a couple factors that play into this for me. One, it's like, do my thumbs get tired? But typically I'll try to be here at least a couple or like several minutes. And so if like my thumbs do get tired, I'll stack them and see if I can get a little bit longer. But then I'll do like Pale's efforts to like, instead of that force just being so specific to this area, like maybe like that area, I'll do a Pale's effort to reinforce that, and that'll kind of make it more global and give myself a break. So to answer your question, it'll be 2 minutes to 10 minutes. And I could just sit here and toggle back and forth until we're like all the way to his full end range of motion, which is like down here. So that's where we'll try to end up. And we'll just kind of work this whole line up the scar. Like the scar is like just a nice path to follow. Does that answer your question? And this is like the least sexy portion of like training, is like, check this out. Questions?
I can, Doc said I could aspirate the cyst.
Okay.
Like,
Yeah.
I was thinking about waiting until I did more work and got more workspace. And I guess it can keep filling up whenever the knee gets inflamed and swollen. That's kind of what fills it, is the swelling elsewhere.
Mm-hmm.
So I was thinking about that. Not a question.
Okay. So hold your leg here. And it's also, Chris just put Shea better on, so my thumbs are sliding.
I wanted to make it easier for you.
So that adds a different component to the treatment. So with that, now we'll just take a break and reinforce that input with light loading. So again, the connective tissue has to be able to resist force in order to transmit force. Does that make sense? So if this thing can't withstand a force, it'll be injured. Because if load exceeds capacity, off she goes. And he's already experienced that once. So here we're just introducing a couple things. So again, light loading. So this thing learns this behavior of loading at length and absorbing and dissipating force through that tendon. Relax.
And I can't do this in a leg extension.
Okay.
I can't do this in like a leg extension machine.
You can if your leg extension machine can get you into this position. Again, it has to be like at length. I mean, you can do load-bearing capacity inputs in positions, but that's a different input
But I don't
than
need
that.
those positions, like this position.
Yeah, so there'll be different, like I said, there'll be slightly different signals, meaning you'll be training at length, whereas you'll be just training a position and training to like generate force and absorb force into that tissue versus the actual architecture at length. Yeah. So we'll do one more there just for good luck. And so we'll keep him at length, again, reinforcing our manual treatment into that tendon. Again, just forcing all that load into exactly where we want it, which is that patellar tendon. Keep coming. And we haven't yet, but we can also, because we haven't done a workspace or joint space input yet, like we could have the knee rotate in either direction and then load it the same way. So we can bias IR, we can bias ER, and then load it slightly different. Chris is really starting to shake now, so this is good.
Shake and bake.
Give me a little more and just kind of match me.
I was.
You can see as force increases, you can see his motor system just kind of fighting, and he has significantly lost the ability to produce force. No offense. Relax. Yeah. No, it's just passive. Yeah, so when I'm in here doing that, that's a passive input, and I'm the one generating the force.
That's the best part.
Yeah. And then we just reinforce that through the internal environment. So I just cue it to generate that stuff into here, and it goes, like with the FR, it's very specific where I'm at. And then when we do the isometrics, like it obviously gets like dispersed outward. Okay, so now we circle back to here, and we want to create internal rotation, but more actively. So we have the passive workspace. Relax. And so what we're gonna do is I'm gonna make Chris. We're gonna spend a little time here so he can like passively feel the length occurring and that information is going to the nervous system, and he can learn to like what this space feels like. So we'll spend a little time here, and then we'll kick it up a notch because we want him to have the strength to be here and to get here. So pull your ankle back towards you and go into dorsiflexion for me. So you feel that rotation?
Yeah.
You feel it occurring.
Yeah.
Drive your heel down into me. And nope, relax. So do it again and watch your foot. So see how when he pulls into me, he goes into ER. So pull less so you don't do that because we want to stay in IR. You feel like you got it?
Yeah.
Hold that. So I passively took him there, and now I'm making him hold this position. So he's using a muscular input to hold here and relax. Let's see if we can get him there again. I'm not going to give you the knee this time, so see if you can hold here and just keep cranking that over as best you can.
But you're not going to give me
I'm not going to give you my knee.
Why gotta be me?
So you feel me turning you.
Yeah.
Can you guys see me actually turning his tibia? So hold that. So right out of the gate, pause. I can feel him do that. You can probably see him. So his nervous system knows that he doesn't have this. So he naturally goes, I'll fake it by doing hip internal rotation. Ready?
No.
Hold. That. Turn. Keep turning. Keep turning. Keep turning. Better. Keep turning. Keep turning. There you go. Great work. Keep holding. We're going to hold a few more seconds. And relax. Say that again.
Does it matter where Chris is mentally cueing himself for internal rotation?
That's a Chris question.
I think it does.
And I can cue him too if like I see things go awry. So like I said before, like I felt him go into IR immediately, so I killed it because he naturally thinks he's doing it, but that's just how his nervous system organizes when it's told to do something, and it just is like we don't know how to do that, so here it is.
The only time it ever makes it seem like I might be doing it kind of correct is when I'm using my other guys, my adductors, for the internal, the medial. So that's.
I also don't want to get people used to doing that. So like for medial rotation, I don't want you to depend on your huge hamstrings to get you there. There is a rotational muscle that medially rotates you. That is the first layer on top of the capsule. And that's what I drew earlier, is that popliteus. So I want that thing to come online and be like, oh, fuck. Because I want that deep stuff to be able to work and not depend on like larger linear stuff. But I'll kind of use that cue at first so people can feel their actual knee moving in space. And depending on someone's like kinesthetic awareness, like how good of a mover are they? Like, are they very aware of themselves, or are they just like Joe Schmo Magoo who has no clue, like has never worked out, like doesn't know where they are in space kind of thing? Chris isn't that person, so I can push this pretty quickly. Ready?
Nope.
So again, passively taking him to his full end range and then just saying hold. And again, you can feel him immediately go to the hip. So I'll kill it, hold, and start turning that foot over. That. I'll let you use the ankle a little bit and keep following my pressure. That. Got it? Hold that. So if he doesn't have it, he will immediately like whip out of it. There was a little bit, but he's mostly there. So we'll do one more long set of this, and then we're going to do more active inputs. And this is how we can actually train the muscle fibers of the popliteus itself. So you can see him freaking out there. So just picture that little popliteus muscle holding him here and just like using everything it effing can to stay here. So now we're just going to take that muscle to fatigue and just exhaust it, because that's how we're going to get it to adapt. So come back to neutral and go back into IR where you just were. More. Come back. More. Good. Again. Great. Keep that still. Keep your hips still. Pull that back and rotate. That. Good. Again. And it is rotating. Like my hand is right on top of that tibia. So now he can use like that cue of like, hey, do you feel your tibia rolling underneath my pressure?
Yeah.
There you go. But similar to like when I took my feedback away from here, if I take that away, his nervous system has to figure it out. So I just changed it like completely. And I can make it like more neurologically stimulating, or it can be too much and he'll just shit the bed.
Not literally.
Yeah, not literally. Mess up my shoes, baby. Let's keep going, yep. So we'll know that when he's like totally fatigued and this muscle is just smoked, when we start seeing more stuff here, it'll stop rotating and then watch his hip. It's just going to keep moving. So we'll try to squeeze out a couple more reps. Good. Got to go to fatigue to get that muscle to get that signal of like, we need to adapt to this stimulus. And relax. Because a muscle fiber that's stimulated but not fatigued isn't trained. So we just...
Can you write that down?
Give you a breather there.
It's not trained, what is it?
Yes.
Trained meaning like with the assumption that if it's trained, then there's going to be some kind of adaptation in the tissue.
Correct.
Quotation marks.
And again, Chris made up a good point of the word training, because that's where we're gonna quotes. I didn't make that up, but training as in we're training for a specific adaptation. Right? So the adaptation we're looking for is for that popliteal muscle to improve its slow twitch capacity. And that would be like more hypertrophic effects. Does that make sense? So now, after all that, we want to reinforce this joint workspace, and we're going to introduce the capsule cars first, and we're going to work on that tibial internal and external rotation. And then we'll go into the full workspace of the joint, which will include all the degrees of freedom that a joint does, which are these bad Larrys. And then we can introduce one exercise, only because Joseph and I were just talking about it. Wall bangers. So we can go up like this, pull that ankle up into dorsiflexion, and then we're going to do internal and external rotation of the tibia. And so we're just going to crank in and out of there. Crank's probably not the best word, but what I want you to do is don't just whip through, like find that end range and pause. More. That. And then come the other way. So you can see like his tibia is going into rotation both directions. And again, just hammering home that information to the nervous system. Everything we just did for the last hour. Here's you at a kind of a length, and then just working, especially that IR, where we had the least amount of control. Any questions while he's ripping through these? Keep going. Go 3 more each direction. Mm-hmm.
And it's more than I thought. Like, I think in the textbook, they don't say like 30 degrees, but
Mm-hmm.
you get 30 degrees of tibial rotation at like 30 degrees of flexion.
Oh, wow.
Ready for the next one? Hold here. And so we can do this a couple ways. So we're going to go through the full knee range of motion. So we'll start in flexion, internally rotate, and I'll kind of guide you through here and extend and keep that IR as high as you can. Good. Externally rotate and pull down. Keep trying to externally rotate, not from the hip. Hold here, extend. Pause, rotate, pull down. Keep trying to rotate as you pull down. Keep coming, keep coming. There you go. One more. Good. Rotate, 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 rotate. Pull. Rotate. Keep pulling. And relax. Great. So that's that. And then the wall banger, this is what we used as just like an exercise to do closed chain IR and ER. So I'll show you how to do that. Come on up and get up off my table. Let me just get this out of the way real quick. So I was telling Joseph earlier that a little bit goes a long way on this one, so I'll just demo it first. You're just going to come a little bit away from the wall. You're going to get a nice soft stance, and you're going to rotate and try to touch your hips on the wall. So we just did all of this, and now we're moving the condyle of the femur on the patella. So as I do this, we're going into internal rotation here, despite facing that way. And this one is an ER. We see that? So in Chris in shorts, it'll be more obvious. And don't fall into the wall. Rotate and reach into the wall.
Like that.
Freeze. So someone who has no IR, oh, you fixed it. Do it again. Watch that foot come up because he has nothing here. Keep that foot flat and go a little closer. Yeah, that was for something a little different. So here I just want him to like learn to do this without that.
So keep that foot flat.
Foot's got to be flat.
And then as this gets better, I can move further away from the wall.
Mm-hmm. So Joseph mentioned putting in like a corkscrewing effect. So that will load the capsule a little bit. So picture like an eccentric. So go ahead and try to twist your feet into the ground like that. And you should feel some torque in your knees. Got it? Hold that and then do the same thing and touch your butt. So keep screwing those things into the ground. Can't go as far. Say that again. Can't go as far because that doesn't have the capacity to do it. So we put a bigger load into it, and as we load, so imagine I give you a bench press with load on it. So I give you 45 pounds, and you're like, okay, I can do that. And then I'm making this up, but like 325 on it, and you go to take it down, you're like, no. That's kind of like what that is. No. So I'm just demonstrating like that's something you can do to reinforce rotation in the knee, but from a closed chain perspective. And then again, the added load is uh, a loaded eccentric. So that's a different part of like a load bearing capacity of the connective tissue that he doesn't quite have all the way to the length. Yeah? Depends on like for him, it would be more repetitions, not to failure, and just condition that knee and that nervous system like, oh, you can be here, you can be here, you can be here. Like we have this. So that would be more in like the information input where we're just telling the nervous system information about being at space and that length, but also totally different thing because we went from open chain the entire time to then closed chain. So it's slightly different information. And Bob's your uncle. Questions, comments, concerns? I can stop listening to myself.